irregular, not sustained, and not indicative of impending delivery. And that's because regular contractions are indicative of impending delivery. Regular and short contractions, obviously. Uh, Contractions of the uterus produce normal labor pain. So that's when the labor comes, the pain comes, obviously. Contractions and obviously the baby going through the birth canal. Okay, so for this one, I always put irregular contractions. All right. Okay, so now they're breaking down first stage, second stage, and third stage of labor. So obviously, this does fall under first stage. Irregular contractions are not indicative of impending delivery. So characteristics of labor pain. So some more notes. So as I'm talking, guys, go ahead and start taking your notes right now. So contraction time and duration. So the interval and the frequency in between them is what matters. When they last 30 seconds to 1 minute and are 2 to 3 minutes apart, delivery of the baby may be imminent. At this point, this is where if you go to a house where there's a pregnant patient and you have this situation going, you're probably better off just staying in the scene and delivering the baby on scene. And if you're a basic life support EMT and not a paramedic or advanced EMT, this is when you would call your advanced EMT or paramedic to the scene, just for more support. You don't know what's going to happen as a result of the pregnancy. Anything else can happen. So you always want to prepare for the worst case scenario. Breaking of the amniotic sac fluid with meconium staining indicates that there may be fetal distress. So meconium really is poop. It's the baby's poop, and if they breathe this in or take this in, it could be very bad for the baby and could even cause some mental issues. So as far as a amniotic sac, remember that's just the sac the baby is inside, and then the fluid inside that sac helps cushion the baby and keep them warm. Meconium is the poop staining, and that means that the fetal is in distress, but that means that obviously something irritated the baby to where they pooped. Does anybody need more time on this slide? All right.
Good.
Okay, so here, first stage, like I said, beginning of contractions to cervical dilation, meaning that there's going to be crowning, and then from crowning to the actual entire birth of the baby, your second stage, and third stage is from the birth of the baby until the placenta leaves the inside of the mother. Second stage, like I said, there's going to be full dilation of the cervix. That's the gateway into the uterus, and that's when, like I said, crowning is going to show. Contractions increasingly frequent, labor pain is severe, mother feels urge to push or move bowels. That's another big sign. If the mother starts to feel like they have to push, well, they're going to be in that second stage at that point. It should be. Let's see, EMT will have to decide whether to transport the patient or keep her where she is and prepare to assist with delivery. Now, what this really comes down to is how is the baby presenting? If the baby is crowning and I see a head, that is very normal and that's good. If I see a limb or if I see their buttocks coming out, that's a big red flag. You cannot deal with that out on the field, and you need to go on your rig and get to the hospital as soon as possible. Of course, let them know the situation. Let them know that there's a limb sticking out, the buttocks. So pretty much, as long as the head is what's showing when crowning, you should be okay to stay and play and deliver that baby right there on the scene. Anything else, take that patient to the hospital immediately. So second stage, this would be the crowning stage. There would be crowning coming out until delivery of the baby. After baby's birth, contractions resume until placenta is delivered. Once the placenta is delivered, then everything's complete as far as delivery of the baby, and the third stage is complete. And this is a note right here. I would take this down if you don't have it. I'll give you guys a minute. Delivery of placenta can take between about 20 to 30 minutes, or 10 to 20 minutes according to this slide right here. So go ahead, take a minute, just write that down real quick, and we'll continue on. So that right there's the placenta being delivered. And let's watch this video real quick, see what it's about.
Childbirth is an exciting and rewarding experience. When contractions begin, they usually last for 30 seconds to 1 minute and occur at 2 to 3 minute intervals. Contractions less than 2 minutes apart are a sign of imminent delivery. Mothers that have delivered previously can usually tell you of imminent birth. These women are commonly straining and have an urge to go to the bathroom. Whenever possible, it is best to deliver at the hospital where both mom and baby can be cared for in clean, warm, well-lit surroundings. In cases where the baby is crowning, it is generally advised to stay on scene and deliver, then transport. Once crowning is present, the baby is very far into the birth canal and may deliver en route, which is much more stressful for everyone given the tight quarters and movement in the back of the ambulance. Assisting with a childbirth begins when you arrive on scene. Start your evaluation of the mother and determine if you will be delivering on scene or transporting in an effort to reach the hospital before delivery. Ask the following questions. What is the due date? What prenatal care have you received? Have you had any complications in your pregnancy? Is this your first pregnancy? Describe your contractions. How long and how far apart are they? Have you had any vaginal discharge? What color? How much? Have you had any bleeding? If so, how much? How many pads have you soaked through today? Has your water broken? Do you have the urge to defecate? Do you have the urge to push? The questions in upcoming physical exam are personal and private in nature. Be respectful and accommodating to the patient's privacy by excusing unnecessary personnel from the area and doing your best to keep her covered. The mother may want the father or a friend to remain with her. You should take a sample history and baseline vital signs. Watch for hypertension, which could indicate a serious complication called preeclampsia. Contractions can be felt by placing a hand on the patient's abdomen. However, contractions are usually painful, and mom will generally let you know when they begin and end. If contractions are less than 2 minutes apart, consider staying on scene to deliver, especially if this is not her first delivery. Place absorbent material, such as towels or chucks, on the ground. Move the mother into a supine position, knees up, for examination and possible delivery. Position the mother on the towels or chucks to absorb the blood and fluids expelled during delivery. Drape the mother for privacy. Remove clothing that obstructs the vaginal opening. Examine the perineum to look for signs of crowning, that is, the baby's head presenting through the vaginal opening. If crowning is present, prepare for immediate delivery. Take BSI precautions, including the application of sterile gloves from the OB kit. Clean the vaginal area with antiseptic towelettes. Wipe in an anterior to posterior motion to keep from bringing fecal matter into the vaginal area. Using clean sheets or towels, drape the delivery area, leaving the vaginal opening exposed. Begin to coach mom to push during her contractions and breathe during her rest periods. As the baby's head presents, support the head and apply slight counter pressure around the vaginal folds to prevent an explosive delivery from tearing the vaginal area and perineum. Make sure the amniotic sac surrounding the baby has ruptured. If not, gently puncture the sac with your fingers, removing it from the baby's face. Once the head has delivered, quickly suction the baby's mouth, then nose. In some deliveries, the umbilical cord will be wrapped around the baby's neck. If this is the case, gently try to slip it over the baby's head. In a scenario where you cannot free the cord from around the neck, clamp the cord in 2 places and cut between the clamps. After the head, the anterior shoulder will deliver first. As the anterior shoulder delivers, apply gentle downward pressure to get the shoulder out. After the anterior shoulder, the posterior shoulder should deliver easily. As the posterior shoulder delivers, you can apply gentle upward pressure to free the shoulder more easily. Support the trunk and feet as the rest of the baby delivers. Be careful, babies are very slippery. After delivery, dry off the baby and continue to monitor the airway, suctioning as needed. Wrap the baby in blankets or swaddling cloth to conserve body heat. Hypothermia in infants is a major cause of infant distress. Immediately assess the baby after birth and 5 minutes later, monitoring breathing, heart rate, crying, movement, and skin color. These are the elements of the APGAR score, and while EMTs are not usually required to know all of these elements, the physician may ask you questions in order to acquire an APGAR score for their records. Keep the baby at the same level as the vagina until the umbilical cord stops pulsating. To cut the cord, place an umbilical clamp 8 inches from the baby. Place the second clamp about 2 inches from the first. Cut the cord between the 2 clamps. Note the time of birth. The mother may want to immediately nurse the baby. This will help control any postpartum bleeding, so encourage her to do so. Even holding the infant to her chest will usually stimulate the letdown of milk and contractions needed to tighten the uterus and stop postpartum bleeding. Placental delivery usually begins several minutes after delivery of the baby, although it may take as long as 20 minutes to begin. Do not pull or tug on the umbilical cord. The placenta will expel on its own. Remember to save the placenta in the plastic bag provided, as the receiving physician will want to examine it. Monitor the mother and baby during transport to the hospital. In some births, the baby will not begin breathing. If the baby is not breathing after 30 seconds of stimulation, resuscitation will be necessary. The EMT should focus on these measures in this order: drying, warming, positioning, suctioning, tactile stimulation, oxygen, bag mask ventilation, and then chest compressions. Of course, any infant who requires resuscitation should have the benefit of ALS. Attempt to meet with an advanced life support unit en route to the hospital. The mother may continue to bleed vaginally, but usually no more than 500 cc's. If excessive bleeding occurs, sanitary pads may be placed over, but not into, the vagina to help control bleeding. Monitor for signs and symptoms of hypovolemic shock, such as tachycardia, pale skin, and altered level of consciousness. If any of the above exist, treat for shock and rendezvous with ALS. Massaging the uterus through the abdomen often stimulates uterine contractions, which stops the undesired bleeding. There are several complications to childbirth. Here's how to handle the most common. Breech presentation. This occurs when the baby's buttocks or feet present first, instead of the head. Position the mother head down with pelvis elevated. Support the body as delivery progresses. Provide high-flow oxygen to the mother and begin rapid transport immediately, as the mother may need surgery to get the baby out. Prolapsed cord. This is the condition in which the umbilical cord presents first instead of the head. As delivery progresses, the cord will be caught between the head and vaginal wall, obstructing blood flow to the baby. Position the mother head down with her pelvis elevated. Insert several fingers into the vagina to keep pressure off the umbilical cord. Cover the exposed cord with a moist, sterile towel. Provide high-flow oxygen to the mother and begin rapid transport, as surgery may be required to save the baby. Limb presentation. This occurs when instead of the head crowning, you may see an arm or leg. Again, position the mother head down with her pelvis elevated. Provide high-flow oxygen to the mother and begin rapid transport in the event surgery is needed to extract the baby. Meconium. This is amniotic fluid that is green, yellow, or brown in color. It is an indication of fetal distress and that the baby has had its first bowel movement while inside the mother's womb. When meconium is present, suction the baby aggressively before stimulation. Mouth first, then nose. Monitor closely and provide resuscitation if necessary. Meconium babies often have respiratory compromise and may need oxygen, if not bag valve mask ventilation.
Wow. That video actually covered a good chunk of the whole lecture, so that's kind of good. First time I've seen it. All right, so patient assessment, woman in labor. Assessment focused on imminent delivery. Name, age, expected due date. All right, so expected I can't talk. Due date helps because, well, obviously, if the patient is having a premature delivery, you would know based off that due date, right? The reason that whether it's the first pregnancy or not, why that matters is because first pregnancies tend to tend to take a lot longer than your second, third, or fourth pregnancy because the body's not, I guess it's not adjusted yet, and it's the very first pregnancy, so it's gonna take longer typically. So that's why that helps you out. Has patient seen doctor about pregnancy? So this helps because if the patient has not seen a doctor, they have no idea what the baby's condition is. All right, they haven't been taking any vitamins, they haven't been getting checkups, they just don't know what's going on with the baby. So because of that, you have to prepare in the case that the baby might have some kind of medical issue, might need to be resuscitated, and that's how that helps you out. When the labor pains begin, that just lets you know how far along the patient has been in labor, and that kind of goes back to whether it's the first pregnancy or not as well. See, assessing the woman. Patient feeling the urge to push or move her bowels, that lets you know that the baby is coming, it's imminent. Obviously, crowning, another one. It's imminent, the baby's gonna come out. Feel for uterine contractions, take vital signs. So that's crowning. Finding that might indicate the need for neonatal resuscitation. Assessing the woman in labor. Findings that might, okay. So like I said, no prior prenatal care. This might be an indication, and you would get this answer from here, obviously. So that's why that matters again. Have you seen a doctor? Have you been seeing a doctor? Do you know where your baby is, how they're doing? If no, then get ready to maybe aid whenever the baby comes out. They might need some help, additional help. Labor induced by trauma, multiple births. So the whole trauma situation, um, if the patient, what the pregnant patient was involved in a car accident, and I talked about it, I think, in last classroom, was that force could be so powerful that it can actually, let me see, that it can tear the placenta from the uterine wall, and that can bleed out. Now, if there's a complete tear, that's an issue for the baby because now they have no supply, they have no oxygen, no blood supply, nothing, and that's why a trauma situation can lead to you having to resuscitate a baby after birth. And see what else? Multiple births, that kind of self-explanatory. Findings that might indicate the need for neonatal resuscitation. History of pregnancy problems. So usually if a pregnant lady has had difficult births before, they're prone to having that again. Labor induced by drugs, meconium staining, we talked about what's going on with that already. See, how can you get necessary information from a patient who may be having uncontrolled pain and contraction? So somebody answer that for me. How will you be able to get information when the patient themselves are in so much pain that they can't answer you.
Maybe from a partner?
Yeah, so from the partner, from the husband, the whoever the partner is, they should have information if they're there, because usually partners kind of talk about that, right? If they care, they talk about what's going on with the baby, have they gone to the last appointment, what they say, what happened. So yeah, so the partner would be your best choice. If not, then any family member there should know something, hopefully. Normal childbirth. It's not the babies, mothers do. Am I wrong? Preparing the mother for delivery. Control the scene. So you want to get anyone that's not involved and that's not pertinent out of there. The only person that should be there besides the people delivering or helping deliver is the partner of the patient. That's the only person that you want there for support, because they're actually going to make the situation better for you in most cases. See, place mother on bed, floor, or ambulance stretcher. You want them flat on their back for delivery. Obviously, take all the clothing that's obstructing the vagina so the baby can be delivered. And you guys will always have what's called OB kits. And everything you need for that delivery should be in your OB kit. And they showed you the OB kit in the last the video that I just showed you guys. If possible, make environment as warm as possible. This is kind of tells you the stages, position them. Then you want to drape them. Obviously, this would help for all the fluids that come out. On top of this, it's a good idea to have this to have another blanket to cover everything that's going on down here, if possible. And this is your OB kit. So this is everything you need for your patient to deliver that baby. All right, guys, let's take another 30-minute break. We're gonna go over